So I'm going to take the alternative viewpoint to my friend Xiaoliang Chen and talk about true distal left main lesions and the provisional, and the title was or reverse provisional T, tap or culotte, which strikes me that the title writer didn't quite follow the meaning of provisional, because all of these are, in fact, provisional techniques. And so the only word that is required there is actually provisional. So the provisional approach is the most flexible of all approaches to bifurcations. It treats them in a sequential and stepwise manner. It's a logical, planned, progressive, and systematic approach. And key to it is that the layers of complexity are added as necessary and only as necessary. So you stop when you have a good result. This means you may end up with one stent, you may end up with two, but as Jens Lassen says, if you start with two, you can't end up with one. So in the case of a left main true bifurcation, you would stent the main vessel, proximal optimize, and then ask yourself, do we need now to do more? If you do, you would rewire the side branch, say the circumflex, and do a kissing inflation, and ask yourself again, do we need to do more? And if you do, you'd stent the side branch in whatever manner you are most comfortable with or is most appropriate, then kiss, then repot, and again, do we need to do more? So at each stage, this treatment algorithm, if you like, is logical, sensible, straightforward. It's rigorous, it's flexible, it's fully versatile. It can be applied to pretty much every anatomy that you can think of. And it offers you crucially the option to do only what you need to and not what you don't. So I have to ask why DK Crush has been so popular. And there are two reasons. One is the data, and the second is the aesthetics. If you like, cardiologists do, I think, enjoy doing complicated things and can be beguiled by the immediate angiographic result. It's a relatively complex procedure, so at the end of a good DK crush, the cardiologist feels good about themselves, and they feel good because there's a lovely angiographic result, not taking into account the fact that where there are two stents when there might have been one, of course, there is the additional risk or opportunity for restenosis or stent thrombosis. There are some key drawbacks to the DK crush. It is inflexible because it does commit you to two stents from the start. It does require many steps for successful completion. It is quite a complex approach, and each procedural step that you add does offer you an original, novel, and potentially creative way to totally mess up your case. It does leave a triple layer of stent on the inner curvature of the main vessel, however short that triple layer is, and it does offer the opportunity to wire outside the stented area and leave an unexposed, uncovered area of vessel that's been injured. What of the data though? Now, these trials have been excellently conducted and huge numbers recruited in record time. I think though it is important to mention some potential differences between these studies and other studies that have been done before. So in the DK Crush 5 study, the pot wasn't mandated prior to rewiring in the provisional strategy, and there was an opportunity to pass behind the stent. And in that study, nearly 50% of cases had crossover to two stents. So that always undermines the comparison between studies when that happens. If we look then at the definition study more recently completed, side branch predilatation was strongly discouraged, but still happened in nearly 50% of cases, and a side branch kiss in the provisional group was only seen in a quarter of cases, despite the fact that these were long and greater than 70% side branch lesions. So essentially the side branch, which in this case is a main vessel, was untreated in 3/4 of the cases. So perhaps it's not surprising that the results were to a certain extent biased in favor of the DK crush outcome. We saw some surprising results in terms of stent thrombosis. So provisional T 3.3%, which is very high, DK crush very low. It was unfortunate that the planned angiographic follow-up, which was due to occur beyond the 12-month primary endpoint, actually quite often occurred before. And you can see here in this graph the effect, the oculostenotic response perhaps, when restenosis that was not clinically apparent was seen at an early repeat angiogram. The side branch lesions were very long in these studies. DK crush 16 millimeters, definition 20 millimeters. And actually these are lesions we don't see very often in Europe or the US. So there's something different there. And of course, these might well be seen to require a stent in their own right. And that suggests that maybe the Chinese patients are a bit different. The disease pattern is a bit different with such long side branch disease lengths, but also that the Chinese approach or methodology for coronary intervention is also different, and perhaps they're particularly skilled and aligned to the concept of the DK crush and not so wedded to the concept of provisional. So of course, whatever you believe in more, you will tend to do better at. All of this, I think, hopefully will be looked at in a slightly different way in the EBC main study, which should report in the spring. And then we will have some interesting data to compare between the two geographies. Thank you very much.